Good evening, everyone, and welcome to the Singapore Cancer Society's Prostate Cancer Awareness Webinar. I'm Annie, your moderator for this evening. A quick introduction about Singapore Cancer Society. It is a community-based voluntary welfare organization with a mission to minimize cancer and maximize lives through its programs. Some of the programs include public education, screening, patient care services to needy cancer patients, hospice home care, financial assistance such as cancer treatment subsidy, as well as rehabilitation support programs. We will end today's session with a Q&A, so in case you have any questions that you would like to be answered, remember to submit your questions by clicking the center icon at the bottom of the screen or leave a comment in the comment section. We will try to answer as many questions as possible. In the event we're unable to answer all of them today, we'll pick a few most commonly asked questions and post it to our No Cancer to Beat Cancer microsite. Today, we have two doctors with us who will be sharing on the signs, symptoms, and treatment options for prostate cancer. We have also invited a prostate cancer patient to share his inspiring fight against pre-primary cancer. Without further ado, let's welcome Dr. Tan Teck Wei, consultant urologist at the UroHealth Medical Clinic Singapore, to share with us the risk factors and diagnosis of prostate cancer. Dr. Tan, please.
Hi, thanks. And thanks, Annie, for the introduction. So I'm Teck Wei. I'm a consultant urologist at UroHealth Medical Clinic. So I'll be sharing on some of the risk factors and how we diagnose prostate cancer in Singapore. So let's go through the basic anatomy. So this is actually a diagram showing some of the organs in the lower part of the male body. As you can see, in front is the penis, behind is the rectum or the back passage where you pass motion. The bladder is the organ that stores urine. When you feel that the bladder is full, you go to the toilet, the bladder will squeeze and the urine will come down the urine pipe or the urethra and exits through the penis. So the prostate lies just below the bladder, so it is part of the urinary tract, but it's also part of the reproductive tract because sperm is produced from the testis, and there is a separate pipe that connects the testis to the back of the prostate, and sperm enters the prostate through the seminal vesicles. So the prostate is part of the urinary tract as well as the reproductive tract. So in terms of prostate cancer, it is the second most common cancer in Singaporean men, the fifth most common cause of cancer death in Singaporean men, and roughly there are about 1,000 cases of prostate cancer diagnosed every year in Singapore. About 1/3 of cases are diagnosed pretty early when the cancer is mainly within the prostate, what we call stage 1 and 2 prostate cancer. About 1/3 is diagnosed when the cancer is a little bit more advanced, it's starting to come out of the prostate, stage 3 prostate cancer. Roughly about 1/3 of cases are still diagnosed when the cancer has already spread, or what we call stage 4 prostate cancer. So this is just some pictorial diagram showing the different stages of cancer. Stage 1 cancer, you can see this yellow dot is when the cancer is very small or within the prostate. Stage 2 cancer, the cancer is a little bit bigger, but it's still well within the confines of the prostate. Stage 3 cancer, the cancer has started to come outside the prostate. And in stage 4 cancer, the cancer has invaded other organs. It may have gone backwards towards the rectum, in front towards the bone, or may have spread to other organs or other parts of the bones in the body. So what are some of the risk factors that we know about prostate cancer? Obviously, the number one risk factor is age. And almost all men above the age of 50 years old will be at risk of developing prostate cancer. Family history plays a role as well. So patients with a family history of prostate cancer are at increased risk of having prostate cancer. In addition, patients with a strong family history of breast cancer in the females in the family, the male members of the family may be increased risk of having prostate cancer due to the effects of the breast cancer gene. In terms of ethnicity, Black men are at high risk of having prostate cancer as well. So a very common question and something that a lot of people are interested in is whether diet plays a role in prostate cancer. There have been so many studies on the role of diet in prostate cancer. Unfortunately, at this point in time, we cannot say that there's very strong evidence of any food that can prevent or reduce prostate cancer, although there's a lot of interest in things such as tomatoes and soy products, but we can't say at this point in time it's very strong evidence to promote the usage of these food products to reduce the risk of prostate cancer. So how do we detect prostate cancer in men? So it's usually, we suspect men to have prostate cancer if they have one of these two abnormalities. Firstly, as part of the checkup, the doctor will insert a finger into the man's rectum. If they feel an abnormal lump in the prostate, they may suspect the man of having a prostate cancer. The second thing is a simple blood test known as the prostate-specific antigen blood test, or the PSA blood test. If the blood test level is elevated, then the man may be suspected of having prostate cancer. So if you have either of these two abnormalities on the rectal examination or abnormal blood test, the doctor will usually recommend you to go for a prostate biopsy, which means insertion of needles from the back passage into the prostate to take some samples to send for testing. Because only by looking at these samples on the prostate under the microscope can you say whether a patient has got prostate cancer or not. So to guide the biopsy, usually the doctor uses an ultrasound to visualize the area of the prostate to direct the needles to do the biopsy. But unfortunately, ultrasound doesn't give the doctor enough resolution to see clearly. You can only see the outline of the prostate usually, and usually the doctor will choose randomly 12 areas of the prostate to take for samples. However, these 12 areas are, because they're taken randomly, you may miss small areas of cancer. And that's why, in the old days, men may be subjected to multiple prostate biopsies because you may, miss the small areas of cancer that is not visualized or not visible on the normal ultrasound. So how can we better diagnose prostate cancer? So sometimes we say prostate cancer, looking for prostate cancer is a little bit like looking for a needle in a haystack. So when you look for a needle in the haystack, the magnet helps. So in prostate cancer, the magnet helps as well, what we call magnetic resonance imaging, or MRI. This is a form of a scan which gives us much better resolution to look within the prostate. These are some of the images showing basically a very tiny 6 millimeter area that is abnormal within the prostate. This will not have been visible on ultrasound, but because you can see these areas on the MRI scan, nowadays we know that these areas are more likely to harbor prostate cancer. And we have the technology nowadays to match the image on the MRI with the image on the ultrasound to target these areas of biopsy. So nowadays, the accuracy of a biopsy is improved by doing MRI targeted prostate biopsy. So this is my last slide, just some take-home messages on the top. Number one, prostate cancer is common. Age and family history are the main risk factors in Singapore. At this point in time, we can't specifically say that there's any dietary recommendations to reduce the risk of prostate cancer. And an abnormal PSA blood test or a rectal examination should trigger a need for further evaluation, and this is usually done with an MRI scan and followed possibly by a prostate biopsy. Thank you.
Thank you so much, Dr. Tan, for the insightful sharing. Next up, let's join Dr. Jonathan Tay, Senior Radiation Oncologist at the Asian Alliance Radiation and Oncology, to learn more about the non-surgical treatment options for prostate cancer. What are the options and how do we choose? Dr. Jonathan, please.
Okay, good evening. I'm Dr. Jonathan Tay. I'm a radiation oncologist from Asian Alliance Radiation Oncology. I'd like to thank the SCS for inviting me to speak at this webinar. So my topic is non-surgical treatment for prostate cancer. Because I'm not a surgeon, I'm a radiation oncologist, and I treat patients non-surgically, mainly with radiation. So can prostate cancer be cured without surgery? Is prostate removal the only way? And the answer is, in terms of the standard curative options for prostate cancer, it's not just surgery, but also radiotherapy as well as active surveillance. I will go into more detail. So stage for stage, no matter whether or not you choose surgery or radiotherapy, survival is the same. So when I look at a patient, what are the factors that affect my treatment decisions? First thing is, where's the stage? Where's the cancer or the stage? And how aggressive do the cancer cells look? That's the Gleason score. Is there a lot of cancer activity? And I use the PSA blood test to assess that. And of course, in any cancer patient, we have to assess how fit is the patient. Does the patient have medical problems? What's the patient's likely life expectancy if he didn't have prostate cancer? So I think Dr. Tan has gone through with the stages very well already, so I will not repeat again. I'll talk a little bit about Gleason score. So Gleason score is what the pathologist rates the cancer as in terms of how aggressive it looks under the microscope. So for example, when a patient has a biopsy of the prostate, then the pathologist will assess the cancer cells. So prostate cancer has very varied behavior. Everyone's prostate cancer is different. And that is characterized by the score. So a low Gleason score of 6 usually means a slow growing cancer, and a high Gleason score of 8 to 10 means that the cancer may grow more quickly and spread. So the prostate cancer can be very tame, like a pussycat. It may not harm the patient in his lifetime, but the prostate cancer can also be fierce and deadly, like a tiger. So, taking into account all these things, we radiation oncologists and I think urologists as well do characterize prostate cancer into risk categories: low risk, intermediate risk, or high risk. So a low risk patient must have everything low risk. That means it must be low stage, it must be a small tumor, it must be a non-aggressive cancer, and the PSA must be low. But the moment a patient has any intermediate risk factor or high risk factor, then they are either intermediate or high risk. Okay, so back to the treatment options. There's active surveillance for low-risk cancers. There's surgery, which I will not elaborate upon because that's not my field. And there's a radiotherapy, which is non-surgical treatment. And there are a few types of radiation that can be given. Okay, so active surveillance is a way of monitoring low-risk prostate cancer, the pussycats. So the aim really is to avoid or delay unnecessary treatment for men with low-risk prostate cancer. And therefore, by delaying treatment, we can actually delay them ever having side effects. So that's done by observing the men very closely, by checking their PSA every few months, doing a prostate exam, and a repeat biopsy is recommended, just to make sure that the pussycat really is not a tiger in disguise. So if any of these tests suggest that the cancer is growing or getting more aggressive, then treatment is done, either surgery or radiation, to get rid of the cancer. Or if the man doesn't want to have any more surveillance, he can have surgery or radiotherapy when he chooses. And the truth is, even with active surveillance, about more than half of men end up getting treated eventually during their lifetime for their cancer. But the good thing to note is that with this approach for low-risk cancers, men who choose this approach have a less than 1% chance of dying from prostate cancer in the long term. So it is a good option because many men can avoid treatment with side effects if their cancer is low risk. Then I go on to the main non-surgical treatment, which is radiotherapy. So what is radiotherapy? It's using high-energy radiation directed at the cancer. And this radiation damages the cancer cell DNA beyond repair. This makes the cancer cell stop dividing and it will die. So radiation is different from surgery. It's painless. There's no sensation at all. So anesthesia is not required. And each session only takes a few minutes. And one form of radiation is called external beam radiotherapy, in which we use high-energy X-ray beams delivered from a machine called a linear accelerator. It looks like this. Okay, so it's directed from outside, from the machine, into the prostate to destroy the tumor inside. And it can be used for a variety of prostate cancers, both locally, as well as regionally advanced prostate cancer. And sometimes combined with hormone therapy for best effect. When we give radiation, we are concerned about the organs nearby. So we are concerned about the bladder above, concerned about the rectum or back passage behind. We're concerned about the urine tube or the urethra that runs through the prostate. And we're also concerned about this thing called the penile bulb, which is at the base of the penis, that does contribute to erectile function. So how do we avoid treating these organs? Because all we want to do is to treat the cancer. We don't really want to treat the other normal organs around. So we do that using technology. And the standard technology now for prostate radiation is intensity modulated radiation therapy, IMRT. So by using advanced computer planning, the radiation area can be sculpted to match the complex curve shape of the prostate. right? So we can direct the high doses of radiation through the prostate while avoiding the rectum behind. And that reduces the side effects quite a bit compared to the past when we could treat the prostate, but we also treated the rectum to quite a high dose as well. And because treatment is so complex and the shape of treatment is complex, then we need to have good visualization of what we're treating. So that's why we need image guidance. This really means that our treatment machine has a scanner. So every day before the patient has treatment, we scan the patient and we can see where the prostate is, and then we can adjust the position and direct the treatment precisely through the prostate and try to avoid the organs nearby. So for a long time, radiotherapy had to be given pretty slowly. You had to give a small dose each day. So we used to give 37 to 40 times daily over 7 to 8 weeks. Thankfully, there are new regimes. Now it can be given 20 times over 4 weeks. So we cut the treatment time by half. And that's because we can use IMRT to make the treatment more safe, and therefore we can give the treatment faster. So what are some of these side effects one gets with radiation? So you can have problems urinating or even have diarrhea during the treatment, but these are early side effects. They will come and they will go within about 1 to 2 months after treating. Okay, but giving radiation to the prostate can also give rise to small risk of late complications. When I mean late, I mean a few years after treatment. One is that it can affect a man's erectile function about 20 to 40% of the time. And a small percentage of men can get blood in the stool or in the urine on and off. But the chance of getting serious complications is around 2 to 3%. When I mean serious, I mean a man needs surgery to solve the problem. So then how do you choose between surgery or radiation? So the few things you need to think about is with surgery, there's anesthesia. With radiation, there isn't. Right? With surgery, there's possible post-operation pain. Radiotherapy is painless. With surgery, there might be some temporary incontinence after the surgery, although in good hands, it's a short period. With radiation, incontinence is rare. But surgery is good because it's a one-time procedure. It's just one and done. Whereas for radiation, it's a bit of a bother. You need to come, every day for 4 weeks, Monday to Friday. It's a bit like going to work. Although it doesn't take so long, it's probably a half an hour. And with surgery, there's no long-term risk of bleeding like with radiation. And radiation can also potentially induce a second cancer in the rectum or the bladder. That risk is very small. It's about 1% in 10 years. But there's a risk that surgery does not have at all. So historically, we tend to do surgery for the young and fit patients because they have minimal anesthesia risks. And we use radiotherapy for the older and less fit patients. Okay, so is there something in between surgery and external radiation? Well, the answer is yes. There's a treatment called brachytherapy. So brachytherapy means short, brachy means short, so it's actually short-range radiation. So how this radiation is given is internal, in that we implant radioactive sources into the prostate using needles guided by ultrasound pictures. Now, because we're poking needles into the area, then we require some form of anesthesia, although the operation is not as long as with formal surgery. So it's done by radiation oncologists together with urologists, and sometimes it's combined with external beam radiation. So there are two forms of brachytherapy. There's what we call the low dose rate brachytherapy, which I call slow and steady, because this is in the form of implanting about 100 tiny radioactive seeds into the prostate. And basically, these are left in there permanently, and these seeds release short-range radiation slowly over a few months. But it's a one-time procedure. Just need to do it once, and it can be done as a day case. The other form of brachytherapy is what we call high-dose rate brachytherapy. I call it fast and furious because this is temporary implantation. So basically, we implant radioactive pellets into the prostate via plastic tubes inserted via needles, and then the pellets go into the prostate, and they're left there for a few minutes rather than permanently to release the radiation, and then these pellets are withdrawn. So we use about 1 to 4 courses given over 1 to 2 days to complete the treatment. It's still pretty short. And patient remains in hospital throughout for obvious reasons, because you can't walk around with plastic tubes between your legs. So how do you choose permanent or temporary brachytherapy? For low dose rate, which is permanent, it has a good history of being very effective in what we call localized prostate cancer, whereby the cancer is just inside the prostate. The reason why is because if the cancer is growing out of the prostate and you try to put seeds there, sometimes the seeds can migrate or get lost. And therefore, the place you want to have the radiation will not have treatment because the seed has gotten lost, it's migrated away. Whereas for high-dose rate brachytherapy, you can be more confident of the position. You can insert the needles and the tubes into more hard-to-reach areas like the seminal vesicles high up. And then you have no worries about seeds getting lost because you're going to remove the implant after the procedure anyway. So who's not so suitable for brachytherapy? So patients with a big prostate, patients who already have urine blockage symptoms, may not want to consider brachytherapy as the first choice because these patients can have problems with what we call urinary obstruction. That means unable to pass urine after swelling because of the needle insertion. Patients who have a previous surgery to the prostate to create a channel, through the prostate to allow urine flow, it's a bit more technically difficult to do brachytherapy because there's less tissue to insert the seeds and needles. This is just to illustrate how different brachytherapy is from external radiation. So on the left is external radiation. You can see that the prostate receives the red high dose, but because the treatment comes from outside to in, therefore there's a lot of low dose splashing around the body. Whereas for brachytherapy is quite elegant because the radiation comes from inside out. You can see the high dose goes to the prostate, and because the radiation is short range, it doesn't go very far away from the prostate. So it's very well controlled. Okay, so how do you choose? Well, brachytherapy obviously is a much shorter treatment, over 1 to 2 days, whereas external beam requires 4 weeks. And there's some studies that show that in the long term, perhaps 10 years and beyond, because of such high doses with brachytherapy, men may experience less relapse in the very long term. And possibly because the doses are so confined, they may have less rectal bleeding compared to external radiation. But one thing to note is that specific expertise is very crucial for brachytherapy. Only centers who do a lot of cases will be able to do it well. Whereas for external radiation, all centers can do it pretty easily. The other advantage of external is that there's no anesthesia risk. It's completely non-invasive and painless. And urinary blockage after the procedure is rare compared to with brachytherapy. So then, are there cheaper, better, and faster ways to do external radiation? And the answer is yes. So there is this new way to deliver external radiation called stereotactic body radiotherapy, which is an advanced form of external beam radiation. So stereotactic means that the beams come from many angles and they meet at the tumor, and the treatment area is usually very small and confined. So we can give very high doses to the tumor while avoiding the organs nearby. And it's originally used in the brain and in the lung, but now it can be used in prostate cancer. So in just 5 external treatments every other day, we can complete a course of radiation to the prostate externally and non-invasively in about 1.5 weeks. Which cancers are suitable for this technique? Well, the evidence shows that localized cancers with low to medium aggressiveness do very well with SBRT. For example, this study from America showed that more than 2,000 patients who had this treatment after 7 years had 85-95% cure rates. So that's pretty good. And the important thing is that serious long-term side effects are uncommon with SBRT, meaning that in terms of urine problems at 7 years, only 2.4%, and in terms of bleeding from the rectum, serious bleeding was only 0.4%, and it compares quite favorably with other forms of radiation, including brachytherapy as well as IMRT. In terms of sexual potency after SBRT, it depends on when the patient has the treatment. If the patient is young, less than 65, when they have SBRT, then they can expect after 5 years to have about 60+% potency rate. If you're a bit older when you have SBRT, then that rate drops to about 40%, but it's still pretty respectable. So because we're very interested in doing this for the prostate, we actually started the trial in our own National Cancer Center about 6 years ago to really observe the patients well when they have this treatment. And the study has been completed. We found the same consistent results with the Americans, showing very low relapse rates and extremely rare serious complications. So this expertise is both available in both the public and private sectors. So how do we do it? Well, to fix the position, we use a customized body mold for immobilization. We use 2 kinds of scans to define the target. We use both a CT scan for planning and an MRI for targeting. So the MRI is really good for targeting because you can see the prostate much more clearly on the MRI. And we actually combine both scans so that we can make a good target for planning on the CT. And we minimize collateral damage by giving what we call smaller margins around the prostate. So this purple line is the prostate. And for SBRT, we use a much smaller margin. You see the blue line here, compared to IMRT, whereby we use a larger margin. And because we use a smaller margin for SBRT, the amount of rectum receiving high doses is much less than with IMRT. And because the margins are so small and SBRT requires just 5 treatments, the doctor actually guides the treatment and does the targeting himself, compared to IMRT, whereby the therapist does the targeting. We use what we call a 6D robotic couch that can move in less than millimeter precision to make adjustments. And the treatment is very fast. It takes about 2+ minutes with the appropriate linear accelerator. So just to highlight the differences, SBRT is really quick, 1.5 weeks versus 4 to 8 weeks, just 5 treatments. We use high doses because we are treating a smaller area, and therefore the doctor needs to do the targeting. And one unusual quirk about SBRT is that a large part of it can be claimed by MediShield and MediSave. So it's a good treatment for localized early cancers, and I believe in the future the indication will expand to that for more locally advanced cancers when more studies come out. Okay, so we can't end the talk without talking about proton therapy, because Singapore is going to have, in our small island, 3 proton centers. This is kind of old news because it says that proton beam therapy by early 2020 and ready in 2021, and still there is no proton therapy center available yet, and that's because of COVID. But I do know that by next year, probably we'll have at least one up and running. So proton therapy is exciting because it uses a different kind of beam. So IMRT, SBRT use what we call photons or X-rays, which are essentially high energy light rays, whereas protons are essentially tiny particles from the center of atoms. So the special thing about proton therapy is that you can actually control how deep the beam goes. So basically for X-ray therapy, the X-rays will pass through the target and then it will go beyond the target. And so the areas behind the target will get lower doses. Whereas with proton, you can stop the beam exactly where you want so that it will stop at the tumor and will not go beyond. And this is a plan showing proton therapy on the left and IMRT on the right. So on the left, you can see that some areas of the bladder as well as the rectum have absolutely no dose because of the proton. Whereas for IMRT, although you can treat the prostate very well, because we come from many different directions, there's what we call this low dose splash around the prostate. And because of this decreased exposure to radiation by proton to the normal organs, potentially there can be less chance of having a second cancer. And by right, there should be less side effects in terms of like diarrhea, urinary problems. But so far in real life, it has not been demonstrated to be superior to IMRT yet. And one thing to note is that proton therapy is very expensive. It is going to be 2 to 3 times more expensive than IMRT. So that is a consideration. Now, how do we make radiation even safer? We're always concerned about the rectum and rectal bleeding. So this is going to be available. This is available in Singapore this year. So it's called a spacer. So basically, we insert a gel in between the space between the prostate and the rectum, all right, using ultrasound guidance. And we use a needle to poke in the gel. It's a local anesthetic procedure, so it can be done as an outpatient. And this gel is biodegradable. So what it does is that it actually causes a separation of up to 1 cm between the prostate and the rectum. So therefore, when we deliver radiation to the prostate, we can avoid the rectum we can move the high doses away from the rectum almost to 0. All right, and therefore, when they look at the study comparing patients who had the space or gel versus those that didn't, the chance of having moderate and above rectal bleeding was reduced from 6% to 1%. So certainly a very promising thing that one can do for patients who undergo radiotherapy. That said, it does increase the invasiveness a little bit because we need to poke the gel in via a needle. Okay, you may have heard of other non-standard treatment alternatives like cryotherapy, whereby you put in needles in the prostate and freeze the prostate from inside, or HIFU, which is using a rectal probe to direct high-energy sound beams to heat up the tumor inside the prostate. Now, these treatments sound exciting and interesting, but they have not been compared directly with the standard treatment techniques of surgery and radiation. So at present, they're still not standard treatments. I wouldn't recommend them for newly diagnosed patients. Maybe in patients who have a recurrence, they may be considered, in my point of view. So only time will tell when these treatments will become standard. So finally, just a word about hormone therapy. So hormone therapy, so prostate cancer is driven by testosterone, which is produced by our testicles. So basically hormone therapy is what we call medical castration. That means we inject medication into a person's tummy fat, and this medication essentially turns off the testicles' production of testosterone. There are newer versions that work faster or even oral versions. And essentially, these hormone therapies help radiation work better by killing the prostate cancer cells. And they also help prevent spread of the cancer. So how much hormone therapy do we use with radiation? Well, for low-risk patients, we generally don't use hormone therapy. For intermediate patients, we use what we call short-term hormone therapy, 4 to 6 months. And for high-risk patients, we give them a long course of hormone therapy of 18 months to 2+ years. So when a man has low testosterone level, they could get hot flushes, low sex drive, difficulty with erections, tiredness, and weight gain. But most men do tolerate the treatment okay and can complete their specified course of hormone therapy. So putting it all together for your convenience, all the different curative treatments for prostate cancer, it really depends on the invasiveness. It's different. So surgery is obviously the most invasive, brachytherapy in between, and the rest are non-invasive. There's also a difference in how long the treatment takes. Surgery is really quick, just a one-time treatment. Brachytherapy also pretty quick. SBRT somewhat better, and then the normal radiation takes quite a bit longer. The side effects are also different, which I talked about before, and obviously there are cost differences between the different treatments, with proton being the most expensive. So when we consider a patient who has prostate cancer, then these are the factors that one will take into account: the stage and aggressiveness. The oncologist will recommend the treatment based on this. Patient also has to think about his age, his general health. Can he take anesthesia? Does this patient want an invasive or non-invasive treatment? What kind of side effects that they're willing to take? There are some practical issues. Some patients, they can't take MC to be in the hospital for even a week, so they might not want surgery. Some patients want to work through their treatment. They might like external radiation or SBRT, which is completely non-invasive. And also some patients may have personal feelings about certain treatments. Some patients do not want their prostate removed. Some patients feel it's better to remove the prostate because it involves removing the whole cancer. So all in all, I think it's important to see both a urologist as well as the radiation oncologist, to discuss all the options. So one is informed and one can make the best decision based on their wishes. So with that, I thank you.
Thank you, Dr. Jonathan. We all know that the fight against cancer is never easy. Dealing with one cancer diagnosis is tough as is, but what if one were to face 3 cancers? Let's hear the inspiring story of how Mr. Eddie Lowe, member of the SCS Walnut Warriors Prostate Cancer Support Group, took on the fight against 3 primary cancers. Let's play the video.
Hi everyone, my name is Eddie Lowe and I'm 63 years old, young. I'm currently fighting 3 primary cancers. This is my story of my fight against prostate cancer. Back in 2017, I had an ordinary medical checkup and something suspicious showed up in my chest x-ray. So with that, I had to do further scans and of course later on biopsies. It was confirmed that I had lungs and liver cancer. About a year later, I was diagnosed with prostate cancer. And with that, having 3 cancers, I just have to manage my condition and I had to medically retire. During my treatment for lungs and liver cancers, I have been monitoring my prostate specific antigens, that is the PSA levels. And in 2018, the doctors realized that my PSA levels were above average. And at that point, I already had an inkling or idea that I might have prostate cancer. So I took the proactive step to go online to read up and then reach out to Singapore Cancer Society's Walnut Warriors, the support group, to find out more about the prostate cancer. And my suspicion was confirmed when the MRI and biopsy results came, and that I had stage 1 early cancer, prostate cancer. When all the news came out, I basically shared with my wife. I'm married and have 1 daughter and 1-year-old granddaughter. They were, of course, my biggest supporter in my fight against cancer. My wife so especially with the many roles that she plays at home. Very grateful and thankful for her. They were all, of course, caught by surprise and shocked. But at the same time, they were relieved that my cancers were detected early. On top of that, having a family history of cancers, my parents died of cancer. My 3 older siblings all passed on from cancer. And at one stage, 3 of us brothers were actually fighting our cancer. Well, having 3 primary cancers and later discovering then that I had 1 more cancer in prostate cancer, that definitely caused a lot of anxiety and fears, and I have to deal with it because of financial, and then I go into depressive moods at times, and the usual questions of running in my mind is why me, just 1, but in fact 3 different cancers of and they are major organs. So real confusion sets in, and those are crossroads of decisions I have to make on the choice of treatment and the plan for what's ahead. I continue to just rely on also the professional advice from the doctors, and also to have clarity on those treatment that is coming up. From my experience, self-help played the biggest part in what I'm doing to care for myself, and not to be shy to seek support when it's really required. Support that comes in many forms, rehabilitation exercises, health seminars, nutrition talks, and even counseling. I think counseling is something that many people are afraid to go for, especially for caregivers that is, supporting their loved ones. For me, cancer is not the end. It's actually a start to look at life again and to see what you can do. And you never give up. You don't give up because you never walk alone. This phrase, "you never walk alone," gave me hope. And it's actually my bucket list, being a fan of Liverpool. I went to the stadium to watch the game, actually on the 2nd year of my cancer when I was much better. One should take a proactive role in managing your own cancer, and if you are healthy and you are of certain age, go for the screening that is being encouraged by Ministry of Health and even SCS. I always advocate this: eat right, exercise regularly, and have enough rest. And that's the 3 ERs. So it's important for me that I find a purpose in life, and I know what it is for me. What are you going to live for? Why do you want to fight your cancer? What do you live for? You live for your loved ones, your things that you want to do in life, and therefore find that purpose in life to continue to battle, and that's what I'm doing. So I want to just continue to encourage you to look into that aspect. For me, I'm overcoming 3 primary cancers. It's a journey. It's fun at times actually when I look at it, because with that fun mentality, cancer is not the end. It's just the beginning.
As a cancer survivor myself, I feel extremely touched when I watch Eddie's video. I hope his story has inspired you too. And in case you are looking for more information on the Singapore Cancer Society's Walnut Warriors Prostate Cancer Support Group, please refer back to the link that Sarah has sent to you in the public chat group. You can just click into the link and find out more information. We'll now open the floor for questions and answers. You can now post your questions through the Q&A box or in the comment section on Facebook. And I have already collected some of the questions from the chat box. So let me just read some of the most commonly asked questions. So we'll welcome both Dr. Tan and Dr. Tay to answer some of these questions. So the first question is about enlarged prostate. Is there a linkage between an enlarged prostate and a prostate cancer?
Okay, I'll answer the question. So enlargement of the prostate, unfortunately, is quite a normal part of aging. Almost all men as they age will develop it. There's no strong link between prostate cancer and enlargement of prostate. So they are separate entities.
Another commonly asked question is about the cause of cancer. Is prostate cancer hereditary?
Yeah, so if there's a family history, there's a genetic, I mean, about 1 in 10 men may have a genetic kind of prostate cancer where it's hereditary, but more often than not, there's no family history, and you do develop prostate cancer with increasing age.
Okay, and the next question will be dedicated to Dr. Jonathan. A very commonly asked question is about like, what is the choice of like treatment for prostate cancer? Other than the factors that you've mentioned, is all in all, is there a difference in terms of treatment for young patients and older patients?
Thank you for the question. I think in terms of some treatments, I think most treatments in terms of radiation or surgery, the cure rates are quite equivalent, but I think the age of the patient does matter a lot. So for example, for young patients, many young patients are suitable for surgery because they are healthy, and therefore the risk of anesthesia is low, and the chance that their continence after surgery is good after removal of the prostate is also good. Whereas for older patients, because they may have other medical problems and because of their frailty, then they may not be so suitable for surgery, right? And their continence may not be as good after surgery because the muscles are not so strong. Other considerations are, for example, like for younger patients, if they want radiation, maybe brachytherapy is a good option, because I mentioned that, in the very long term, perhaps brachytherapy controls the cancer better, right? And younger patients may also tolerate the needling and the anesthesia better than older patients as well. So these are some of the subtle considerations that one would have when we're talking about age.
Okay. And another popular question that a lot of like our audience asks is related to lifestyle choices and like, for example, diet, exercise, as well as supplements. Is there anything that can help prevent prostate cancer from a lifestyle perspective?
Yeah, unfortunately, I mean, there's been lots of research on this. There is still no strong evidence. People always say things like tomatoes and soy products, but again, we can't say there's very strong evidence that this has been shown to prevent prostate cancer. So I think the key thing is still to live healthily, try to keep a good weight, because I mean there is some evidence that obesity, increased weight may increase the risk of aggressive cancer. But the key thing is just to live in moderation, keep yourself fit and healthy.
Thank you, Dr. Tan. The following question is related to the signs and symptoms of prostate cancer. What are the most common symptoms of prostate cancer? And what kind of symptoms is like the telltale sign for prostate cancer?
I would say that actually in early prostate cancer, there is often no specific symptoms. Why men come to see a urologist or see their family physician is often due to urinary symptoms. And these urinary symptoms, can be things such as difficulty peeing, the pee becomes slower, they go to the toilet more frequently. But very often these are due to aging and the enlargement of the prostate and bladder problems leading to these symptoms. But because they do see a doctor, as part of the workup for this problem, we need to make sure it's not cancer. So they do get a check in terms of a rectal examination, in terms of a blood test to check for prostate cancer. But by and large, you would say that for early prostate cancer, they themselves do not grow to such a size that lead to any symptoms at all. But it's because of other problems related to the prostate that we detect this early prostate cancer.
And in order to detect prostate cancer, who should pay specifically attention to like cancer screening, and what are the most common ways for like the general public in Singapore to do so?
Okay, so in terms of cancer screening, it is not a recommended kind of cancer. In Singapore, the government only recommends screening for colon cancer, for females, breast cancer, and cervical cancer. But if for men, especially if there's a family history of prostate cancer, usually we recommend screening earlier, usually with a blood test from the age of about 45 and above. Whereas for the common population, usually we recommend getting a blood test, PSA check from the age of about 50 years old. But it's something to be discussed in consultation with your family doctor or urologist.
Thank you. The following question is about like a PSA. Firstly, what exactly is PSA? And secondly, if the patient went for a PSA test and realized that his PSA level is fluctuating, should that person be worried?
So PSA is actually a substance that is secreted by the prostate. It's secreted by both normal, what we call benign prostate tissue, as well as cancer cells. Although we do see that if the levels are higher, the risk of finding cancer is higher. But it is not the most accurate blood test. Usually, when the lab test comes back, the normal range, they will usually give it as between 0 to 4. But when we see, most commonly, men have a mildly raised PSA where the blood test level is just above 4, between 4 to 10. And if they have done studies where you subjected men with this kind of blood test levels to a biopsy, you only find cancer in roughly about 1/5 of these men. So it's about 20% risk of finding cancer. So it is something to guide screening or guide management, but it is still not accurate enough to tell whether a man has got prostate cancer or not.
I think some of our audience would like to hear from Dr. Jonathan as well. Dr. Jonathan, the question is that, this is an interesting question. Does prostate cancer affect sexual health?
Does it affect sexual health directly? Most of the time, no. But if the cancer were to be very advanced and grow out of the prostate and affect the nerves around the prostate, then yes, I think it could affect sexual health. Because the nerves are affected, then you can't have an erection. Yeah, but I think the other thing I would say is that prostate cancer treatment can affect sexual health.
Thank you, Dr. Jonathan. A reverse version of this question is, will increased sexual activity help reduce the risk of prostate cancer?
I don't know, and I do not know of any data of that. Maybe Dr. Tan can elaborate if he does.
Yeah, so again, there are some studies about this, but there's no strong evidence that having more ejaculations will strongly reduce the risk of prostate cancer. There are some preliminary data, but I don't think we can strongly recommend more ejaculations to reduce risk of prostate cancer.
Thank you. The following question is about the survival rate. How high is the survival rate of prostate cancer?
Actually, prostate cancer has pretty good survival rate. I mean, in terms of in Singapore, it's the second highest survival rate after skin cancer. So if the cancer is localized, then your chance of being alive at 5 years is 100%, close to 100%. And even 10 years, close to 90+%. So, but of course, if you have stage 4 cancer, then the survival rate becomes much lower. It's about 30+% at 5 years. But in general, if you pick up cancers early, then I mean the survival rate overall is still pretty good, and that's why prostate cancer is the second best survival cancer for men in Singapore.
That sounds very, very promising. The following question is about biopsy. Can there be damaging effects over the years in active surveillance where annual or biannual biopsy needs to be done?
Most of the time, we would say that the effects of the biopsy are temporary. It's quite common for men to have blood in the urine. If the biopsy is done through the back passage, you may have blood in the stools. Usually this lasts for a few days and it should go off. There's also a risk of infection as well as a difficulty passing urine after the biopsy. But I think by and large, in the old days when they first started a lot of studies on active surveillance, because you're not sure of the progressiveness or the aggressiveness of the cancer, they do subject men to very frequent biopsies every 1 to 2 years. But nowadays, because we can diagnose cancers more accurately with the help of MRI-guided biopsies, we are more confident of the grade or the aggressiveness of the cancer. Nowadays, typically, we will still repeat a biopsy at about 1 year, but after that, we often not do a biopsy on a once a year or every other year. We try to increase the interval between biopsies nowadays because we know that all these biopsies will scare men off surveillance and push them towards treatment. So I would say that nowadays, most active surveillance protocols do not mandate a once a year or once every 2 years biopsies.
Thank you. There's a question about the testicle size. If someone's testicle is swelling and large in size, should that person be worried whether or not it is a sign for prostate cancer?
I would say not. If it's a young man with an enlarged, testis or testis lump, you may need to check for things like testis cancer, which is much less common in the elderly men. But there are other diseases of the testis, but we would say that usually testis swelling is unrelated to prostate cancer.
Thank you. Another frequently asked question is related to the frequency of urination during nighttime. And I've seen like many of the audience asking the same question. What is the normal frequency? What is the range of normal frequency for urination at night? If someone urinates like more than 10 times each night, should that person be concerned?
I would say that frequent urination at night is a pretty complex issue because there are so many causes for that. Causes can range from, firstly, if someone has a sleep disorder, they have insomnia. So very often we see patients with insomnia, they can't sleep at night, they start thinking about things and they go to the toilet frequently in the nighttime. There are other causes of frequent urination at night where people are actually woken up from sleep to pee. Things can be due to things such as diabetes. There can be other hormonal imbalances leading to increased production of urine at night. So, and in addition, of course, you can always contribute it to some kind of bladder overactivity or even a prostate issue. So it is important to, if you have such a problem, to not suffer and to find your family physician or urologist to have further evaluation so that we can decipher what is the exact cause and the appropriate treatment can be given.
Thank you. Dr. Jonathan, the following question is dedicated to you. What is the age range to be considered older patient when we talk about treatment options?
Well, I mean, there's no hard and fast rule, but I would say somewhere between 65 to 70, that kind of range is where the line is drawn usually. Yeah.
And besides genetic factors, what are the other risk factors that lead to prostate cancer?
Besides genetics, well, I mean, in terms of, there are some environmental factors, lifestyle factors that can possibly give rise to increased risk of prostate cancer. For example, as Dr. Tan mentioned, obesity. There's some association between overconsumption of red meat possibly as well. And certain foods are meant to be protective, although the evidence isn't very strong. For example, like tomatoes, green tea, as some food choices that may be helpful.
And the following question is related to a myth of radiotherapy. Will I be radioactive after receiving radiotherapy?
The answer is 100% no. You will not become radioactive. The radiation passes through you, but doesn't stay in you. And so after if one has had radiation treatment, then you can go near children, so on and so forth, give them a hug. It's no problem. Yeah.
Thank you. Just now, Dr. Tan mentioned like prostate cancer is now the #2 cancer among male in Singapore. Is there any reasons behind this increase?
I think the first thing is that people are living longer. So the older you live, the more risk of you developing a prostate cancer. And as Dr. Tay has mentioned, one of the other risk factors may be increasing weight or obesity, and we do see an increase obesity rates and people being overweight in Singapore, and that may contribute to an increased risk of prostate cancer as well.
Thank you. The following question is related to self-examination. We talked about how do we do screening and all. Is there a self-examination that we can detect the early prostate cancer?
Unfortunately, I think it is pretty difficult to do a self-examination of the prostate because it will involve an insertion of the finger up the passage to feel the prostate. So you may not know what you're feeling for, and it's probably pretty uncomfortable as well. So it's not, unfortunately, there's no self-examination recommendation for prostate cancer.
Thank you. The following question is related to the treatment. Perhaps Dr. Jonathan, you can help take this question. Is the freezing method a good bridge between radiation and surgery?
A good bridge? Well, I would say that the freezing treatment is still not established as a standard treatment. The history is not as long, hasn't been properly compared to surgery and radiation. So I wouldn't use it as a first treatment for someone newly diagnosed with early prostate cancer, right? That said, I think in certain cases, for example, if a patient has had a recurrence localized to the prostate only, then I think freezing treatment can be a viable option, because then you don't have to radiate the patient twice, and also surgery is more difficult after a prostate has been radiated. But certainly as a first-line treatment, I wouldn't recommend this freezing treatment, or what we call cryotherapy.
Thank you, Dr. Jonathan. We are almost approaching the end of this Q&A session, so let's have last two questions. Is there a difference in terms of cost of treatment for early and late stage of cancer?
Yeah, so I would think there will be a difference, because the later stage cancers tend to require more aggressive treatment. It depends on what you mean by late stage. For example, if it's a spread, stage 4, spread to areas outside of the pelvic area, then treatment generally is continuous. That means you need to keep having treatment, and it's mainly in terms of drug treatment, for example, hormone therapy or chemotherapy and immunotherapy, for example. That is continuous. So I think eventually the treatment cost will rack up. But if it's early stage cancers, generally are treated with the lowest cost, because for early stage cancers, generally you only need one treatment. So be it surgery, or one course of radiation, or one course of brachytherapy. And in the middle stages, you need to combine treatments. So some patients may need a combination of surgery and radiation to get cured. Some patients may need a combination of radiation and hormone treatment to get cured. So these will be in the middle. So it really depends on the stage.
Thank you. And the final question is related to sexual function after the treatment of the prostate cancer. And it is a huge concern for a lot of patients. What is the rehabilitation required to restore sexual function after the prostate cancer treatment?
Yeah, so deterioration of sexual function does happen with all forms of prostate cancer treatment. It's different between surgery and radiation. With surgery, sometimes erectile dysfunction can be quite immediate, whereas for radiation, it develops slowly over 1 to 2 years. However, there are some ways which I think Dr. Tan can probably elaborate better than me to help these patients, be it through medication like Viagra, and also there may be some mechanical methods which perhaps Dr. Tan can elaborate.
Dr. Tan, do you want to elaborate?
Yeah. So I mean, in terms of the surgery wise, depending on how aggressive the cancer is, because actually the nerves that control erections run right on the sides, on both sides of the prostate. So if the cancer is not overly aggressive, during the surgery, we can try to carefully free off these nerves. If you can preserve the nerves that control erection, then obviously there is slightly higher chance of getting good erections after surgery. And nowadays, if we do preserve these nerves, we put the patient on what we call penile rehab after surgery. They will be started on medications such as Viagra to promote blood flow and erections after surgery. If this fails, sometimes they can buy what we call vacuum devices, basically devices which creates a vacuum, suctions blood towards the penis to promote blood flow. As a last resort, if all these various factors do not work, there are surgical means, including insertion of implants into the penis to generate an erection. So there are ways to restore erections after surgery, or as well as even after radiotherapy, medical means as well as surgical means if necessary.
Thank you so much, Dr. Tan, and thank you so much, Dr. Tay. So we are approaching the end of the Q&A session. Just in case you want to revisit these frequently asked questions and for more information, please visit the Know Cancer to Beat Cancer microsite, where you will find some of the most commonly questions being answered on the site. As we all know, November is the Prostate and Lung Cancer Awareness Month. So don't miss our lung cancer webinar happening next Thursday. And if you're interested to find out more about prostate and lung cancer, you can also head over to SCS website for more information and resources. As we're ending our seminar today, I would like to extend the special thanks to our supporters, including Asian Alliance Radiation and Oncology, National Cancer Center Singapore, National University Cancer Center, Singapore, EuroHealth Medical Clinic, and our sponsors, AstraZeneca, Astellas Pharma, and Johnson & Johnson. We've come to the end of our webinar today. Before you leave this webinar, please don't forget to fill out the feedback form, which will be sent in the public chat and also presented in a QR code towards the end of our webinar in a PowerPoint format. Thank you so much and have a good evening.